Hi there, everyone. This is Julie Haluska, your KHAM webinar chairperson, and I am also a vice president of Health Recon Connect. And we are just going to give this a few minutes before we start the program. We've just waited for a few folks to get on board here. I'm just trying to see how many people are in here. Bear with me here. Okay. We're just going to give it a few minutes, probably start at 12:05, so 4 minutes. So just hang out and relax, and we'll be right back. Welcome again to the webinar. We're just going to give it a couple minutes here before we go live with Centauri today, talking about social determinants of health. In the meantime, I do want to make everybody aware that KHAM will be having their annual meeting in September. I believe it's the 6th. But go to www.kham.org and take a look at the KHAM website to sign up and get your rooms and things like that. See how many people we have in here. We have 10 people. What I'm going to do is I'm just going to go ahead and start the meeting. I'm Julie Haluska again, webinar chair for KHAM. Welcome, welcome. I want you to know that if you've got any questions, to go ahead and put them in the chat box, and then the folks from Centauri will go ahead and answer those as well. And I'm going to turn it over to Scott Golay from Centauri. Scott's the VP there of sales, and Scott's going to introduce our speakers for today.
Hi, thanks, Julie. Can you hear me okay?
Yep,
Yes.
we can.
Oh, perfect. Perfect. Yeah, thank you, Julie. As Julie mentioned, I'm Scott Golay, VP Business Development with Centauri Health Solutions, and working with our hospital clients throughout the Western U.S. Along various service lines, such as eligibility enrollment, out-of-state Medicaid, referral management, and kind of I'll call strategic pricing analytics. I have the pleasure of introducing our two speakers today. The first is Dawn Carter, Director of Product Strategy here at Centauri Health Solutions. Her career in healthcare spans 27 years, which most recently includes extensive experience in developing revenue integrity and quality software solutions with a focus on encounter management, risk adjustment, and social determinants of health solutions for Medicaid, Medicare Advantage, and commercial health plans, as well as providing risk adjustment strategic advisory services in these markets. Prior to that, her experience has spanned across all domains of healthcare, including health plans, provider systems administration, finance, compliance, etc. Her experience also includes multiple teaching engagements in medical administration, billing, and coding. Dawn holds a bachelor's degree in business administration and is passionate about industry speaking, is an author, blogger, subject matter expert in claims, and I believe also is a certified coder as well now. Our other speaker today is going to be Dr. Julie Goldberg, Product Delivery Manager here at Centauri Health Solutions for our risk adjustment platform. She has deep experience both in social determinants of health and bringing voice of the customer into the design and development of our digital health solutions. Prior to joining Centauri Health Solutions, Dr. Goldberg consulted with startups at the intersection of medicine and technology. She's worked in product management, marketing, product design, and with an overall goal of improving the patient and provider engagement, as well as attracting and retaining traction with the customers. Before entering her health technology space, she spent 11 years as a professor studying the underlying causes of health disparities among African American cancer patients at the University of Illinois and University of Illinois and Chicago College of Medicine. She's also the author of more than 50 peer-reviewed articles and professional presentations as well. Dr. Goldberg holds a doctorate in social psychology from the University of California at Berkeley. She also holds a master's in counseling psychology and a bachelor's of arts in sociology from the University of Pennsylvania. So I'm really pleased that these two ladies are able to do the presentation today. And so now what I will do is I will turn it over to Dawn to start us off and walk through our webinar today.
Wonderful. Thank you so much, Scott, for that introduction. We appreciate you and Julie Haluska joining us today. Dr. Goldberg, you can advance the slide where I'll just make a few more remarks of introduction. I just want to say good afternoon to everyone, and thank you for joining today's discussion titled, It Matters to This One, Achieving Better Health Outcomes Through Social Determinants of Health. You often hear social determinants of health referred to in an acronym as SDOH, and may have also wondered why we as an industry should care about it. You might also be wondering why my co-host and I were tapped for this topic. And so before we introduce ourselves further, for the benefit of those who we might not yet have had the pleasure of meeting in person or virtually, I thought I'd take a moment to tell you why we were tapped, aside from the fact that she and I are both very passionate about the topic. Dr. Goldberg is a social scientist whose PhD and work prior to Centauri in academia was directly related to SDOH, and I have been investigating for some time now how SDOH lies at the intersection of risk adjustment and quality, and how there might be opportunities from a product development perspective. Both she and I serve on an enterprise-wide project related to SDOH that is also focused on the potential opportunities for Centauri. Hopefully this presentation will help you understand the complexity of the topic and also why it is critical that our industry is able to benefit from any technology or other solutions that we might be able to develop and offer. Next slide, please. Now, it's highly likely that most people in this audience have at least heard of social determinants of health. Like I said, is also known as SDOH. A quick Google search of the term nets 206 million hits, so it's clearly top of mind for many. And also in the Google, you'll even see that depending upon whom you ask, there can be anywhere from 5 to 12 SDOH. So let's start off with a definition. Now, according to the Centers for Disease Control and health.gov, SDOH are the non-medical factors that influence health outcomes and are the conditions in which people are born, live, learn, work, play, worship, and age. And what's most important to understand about SDOH is that these factors, by and large, are not addressed as part of a standard biomedical health assessment and are very much qualitative as opposed to quantitative. As a result, traditional medical care addresses only 10% of the controllable contributors that make a population healthy. For example, if a patient cannot adhere to his hypertension care plan, if the medication is too expensive for him to buy every month, then outcomes will suffer. Similarly, outcomes will not improve for an obese patient if she cannot afford healthy food options or get to a grocery store miles away from home. Next slide, please. What's most important to understand about SDOH is that these factors, as I said before, are not addressed as part of the standard biomedical assessment, and they're very much qualitative or quantitative. So we know that also, according to a recent report, 68% of members have an SDOH, primarily financial insecurity and isolation, and 60% say they have never discussed this with a provider. Those who do discuss an SDOH with a provider are 2.5 times more likely to accept help from a provider rather than an insurance company. Next slide, please. Now, I'd like for you to think back to the first slide that contained an illustration of the 5 SDOH. How many of you identify with at least one of these or know someone who does? I imagine most of you in the audience are raising your hand. Since many of us are involved directly with members providing care or working with healthcare data or involved with community activities, I'm not surprised it's all of us, really. I know that I experience loneliness, and I work in my community to alleviate food insecurity and educational barriers to healthcare and other resources. As such, As I mentioned before, it is not the responsibility of any one entity to address SDOH. It is, however, the responsibility for each of us to do our part. And on the slide there, you will see what each of us can do. Just to foreshadow, and next slide, please. Just to foreshadow how important it is to pay attention to SDOH, let's take a look at loneliness, for example, which falls into the domain of social and community context. Statistics related to the measurement of loneliness have shown the following. It increases mortality by 45%. It affects 50% of people with dementia. 1/3 of people in the United States are chronically lonely, and it's difficult to address because it's a cluster of emotions. Likewise, health plans that have implemented specific strategies related to reducing loneliness have had the following results: a 51% inpatient stay reduction, a 41% reduction in emergency department use, and an $847 per member per month cost savings, which is not insignificant. Given that a great deal of our industry is comprised of payers who are in turn contracted with providers, all of whom have a vested interest in cost-effective healthcare of those they serve, you can easily see why every type of entity in our industry would be so interested in SDOH, and also how it is not just the responsibility of any one entity such as the government. When you hear about value-based care and population health, it is important to remember that SDOH is a critical part of these kinds of initiatives, and this presentation will help you see why that is. Next slide, please. What's most important to understand about SDOH is that these factors, by and large, are not addressed as part of the standard biomedical health assessment, as we said earlier, and they're very much qualitative. And so you can see here on this slide some different practical examples of what could happen financially from a risk and quality perspective if social determinants of health are ignored. And we'll look at the compliance aspect a little bit later. So let's take an example of food insecurity, which is in the domain of social and community context. Food insecurity is defined as the disruption of food intake or eating patterns because of the lack of money and other resources, and it is not always correlated to poverty, contrary to popular belief. Based on what you see here on this slide, it is highly likely that every one of us in this room knows people who are food insecure or are suffering from chronic illnesses that are related to food insecurity. I'm going to now illustrate this to you with a very personal example. Next slide, please. I want to introduce you to Kayla. Kayla is my 11-year-old daughter's best friend. It is not just because of my job that I recognize some of the more obvious factors in Kayla's life that clearly indicate that she is food insecure and at risk for the chronic illnesses listed a few slides back. Factors such as limited transportation, distance from a source of fresh food, and access to fast food. Therefore, it's not enough for her family just to have SNAP benefits. They need so much more than that. It's also obvious that Kayla's family has limited means to get her to a provider's office, even though her Medicaid managed care organization offers transportation to appointments, and that they spend most of their time at home or in the community. Kayla has a managed Medicaid plan, and so one would hope that for her sake and for those like her, the plan, through efficient and effective use of available data, has recognized that she is food insecure and that community and home-based interventions need to be planned to address her unique needs and prevent the manifestation of costly chronic illnesses. Sadly, that does not appear to be the case. At Centauri, we talk a lot about how we measure the success of the work we do for our clients in enrollment and benefits, risk adjustment and quality, and also about how we affect the members served by our clients at the individual level. We can calculate the ROI of gap closures and quality measures management related to food security to see it. Kayla serves as an example of someone whose life could be changed so much for the better through good data stewardship, and the resultant ROI of that increased health and happiness is incalculable. And this is just for one SDOH. There are more that pertain to her. Let's do our part to make sure Kayla keeps that smile on her face despite the odds. Let's give her a fighting chance at a healthy future free of the burden of chronic illness. She's worth it, and we're worth it. And now I'm going to turn it over to my esteemed colleague, Dr. Julie Goldberg, to dive a little further into incorporating SDOH into health plan and other programs.
Thank you so much, Dawn. And because payers really recognize the importance of stories like Kayla, there's been a great deal of interest in offering this in 2022 for Medicare. You can see that United has both an over-the-counter and food benefit program at 30,000 retail locations through their U-Card. And they also have in-home visits that has a social needs assessment. Anthem, jumping on the bandwagon, they have their essential extras, and that's a flexible spending card that can be used to buy things like dental or vision or hearing related items. They also include a healthy groceries card and in-home support for things like housekeeping and errands, and well as technical support, which I can totally tell you my 85-year-old mother would love to use, because right now I am her technical support. Anthem also includes transportation and meal delivery, a really comprehensive service. Cigna has their social connection program, and that includes assistance for several key activities of daily living, like transportation, meal prep, and chores, and Aetna has a health food benefits card. And these are pretty standard approaches to incorporating SDOH into healthcare. This kind of buffet of services or referrals to their members. And Centauri has a similar array of offerings. Between our Social Services Plus, Resource Connect, and Benefits Plus programs, we perform needs assessments to identify the specific social service needs for things like food, housing, utility, transportation, financial assistance, and then we give those referrals back to our members. And this sounds great, right? You're offering more information to more people with more choices. But honestly, the sheer number of choices that every one of us faces every day can be overwhelming. Starbucks actually proudly announces that when you're deciding what kind of coffee to drink, you can make up to 80,000 different choices in ordering your coffee, from the country of origin of your coffee bean, to the type of milk that you want, to the actual coffee drink, a macchiato, a cappuccino. And this becomes exponentially more overwhelming when you're living at the intersection of multiple SDOH factors. You can see in the cartoon here, of course we can make fast decisions once we've considered the 4,872 factors. Now consider that when you're also living with food insecurity and unstable housing, unemployment, and then add on that an unexpected illness, when your house is on fire. How do you choose which of 30,000 retail locations to use one of two different benefits cards for a variety of services being offered to you? And this has actually been described in the literature as psychological choice overload. People say they prefer more choices, but as you can see in this illustration, with so many fish in the sea, how do you justify picking one out of all of these? And paradoxically, research has shown that the more choices people are given, the less likely they are to make any choice. And this results in delaying making decisions. And if you do make a decision, making a decision that is of poorer quality with which we are less satisfied, or making no decision at all. And actually, Schwartz has a great TED Talk about this called The Paradox of Choice. And this is evident in both low and high stakes decision making. In this example of decision paralysis and a low stakes decision, a grocery store thought that they were going to do a great job and they were going to increase their offering of jams from 6 varieties to 24. And they thought they were going to quadruple their money. But they actually found that when they offered 24 jams, people were less likely to buy anything compared to when they only had 6 options. And this is also seen in high stakes decision making. One study of direct care staff who were considering a special needs program, the more choices they were offered, the less likely they were to make any choice. And when it comes to buying a prescription drug plan, whether you are young or old, the more options you were given, the less likely you were to make a good choice. You were more likely to buy a more expensive and less convenient plan than if you had fewer choices. And again, this cartoon exemplifies this. You see all the cards under the yes, nothing under no. I think I'm seeing a pattern here. We just need to talk to 1,385 more people before we're confident enough to make a decision. And when it comes to your healthcare, this kind of decision paralysis can be incredibly costly. If you delay, your interventions are likely to be less effective or have less long-term benefits, or may not even be available any longer if you've waited too long or if you've gotten too sick. And when it comes to financial costs, obviously the sicker you are, the more costly it is to take care of you. And if your situation is deteriorated, SDOH programs may be more costly to rectify that. Now, I'm not saying that we don't offer choice. Choice is obviously necessary for changing the factors that underlie SDOH, but providing information like a bunch of referrals to people is honestly just the first step in a much larger process, because if giving people information alone were sufficient for them to change their behavior, an entire weight loss industry would be out of business. If you just need to be told what was good for us and we change our behavior, that'd be great. But the truth is it changes a process. And our messaging has to be tailored to where people are along their path to help them take action. And Prochaska and DiClemente actually have one of the most robust theories about behavior change. And they posit that there are 5 stages to change with sort of an unofficial 6th stage. And that we all start in pre-contemplation, where we have no intention of changing our behavior. And this isn't necessarily because we're in denial. It may be that you just can't address this issue because you have so many other competing priorities. If my house is on fire, don't give me information about where I can get fresh vegetables, because presenting options at this stage can actually be counterproductive and even backfire. So how you want to frame the message for folks in pre-contemplation is that choosing to engage in the same behavior is actually a choice. And if they think about that, I keep doing the same thing every day, and that is a choice that I am making, they may be able to contemplate that there's a different choice that they can make. And that can transition them from pre-contemplation to contemplation, where they're willing to consider taking action and making different choices. And this is where you get buy-in to the possibility of change, but you don't jump from contemplation to action. There's actually an intervening step called preparation. And that's where you start making your plans to change. But what's key here is that you have small, achievable goals. Because again, paradoxically, if your goals are too ambitious, they can also backfire. And psychology has labeled this the aspiration gap. So let me give you an example of a diabetic patient who is obese, she has high cholesterol, she has high blood pressure, she's sedentary, and she decides that not only does she want to lose weight, but she wants to join a gym and even become a triathlete. Now that sounds like a great goal, but the difference between where she is now and where she aspires to be, that gap is so big that it actually will discourage her from taking any action. And that's called the aspiration gap. And it's kind of like Goldilocks. If it's too big or too small, it can result in failure. It has to be just right so that it can motivate action, and these aspirations can become inspirational and motivate realistic and attainable change. And I actually found this out for myself in my own research when I was working with juvenile delinquents. Because I wanted to know, does it even make sense to think about choice when you're talking to folks who are at the intersection of like every imaginable risk? So I was working with kids who had not only committed severe acts of violence for which they'd actually been caught and put into jail, but they were the victims of violence, they'd experienced violence vicariously in their homes, and they had been inducted into gangs at a very young age. And so I wanted to know, does deterrence, which requires you understanding that the actions I take now, like shooting someone on the street, will have actions in the future? Could a deterrence-based program to reduce gun violence work on the streets of LA with folks who are lifelong gang members who clearly have very few choices about their future? So to understand whether we could go forward with this deterrence, I needed to understand, what do they think about the future? Because future consequences are core to deterrence. So I just needed to understand what they were thinking. So I asked them just some basic questions, like, do you think you're going to be able to complete high school or get a full-time job when you get out? Now, half my participants, when I gave them this hypothetical situation where gun violence was possible, they were exactly what you'd expect them to be. They said that not only would they shoot first and they'd shoot to kill, because everyone was their enemy, but when it came to their future, they didn't think they'd live past 18, so why did it matter? And honestly, this is pretty realistic. of what their lives look like outside of juvenile detention. But what really surprised me, the other half of my sample, when I gave them that same scenario, they said to me that they were pretty sure they could talk their way out of a situation that typically leads to gun violence. And they also said, when I asked about their future, they said there was a 99% chance that they could get their GED while they were still in juvie hall and then get a full-time job when they got out, even if that meant they had to leave the only neighborhood they've ever known their entire lives. But when talking about this vision of the future, I don't really think that it was expectations I was hearing. They tended to take a deep breath, sit back in their chair, and I really think that they were talking about their aspirations for their future. But these aspirations could only translate into real behavior change if they were given the tools and the resources and realistic steps to achieve them. And tragically, most recently with the pandemic, aspirations for all young people feel unattainable. A recent census in the UK found that 41% of all the young people they surveyed believed that their future goals were impossible to achieve. And this rises to over half of those from a more disadvantaged and poorer background. But let's say that you are able to make these realistic, attainable plans and move on to action. You're not done. Your plans are great, but whether your plans succeed isn't only based on your good intentions. There are really real-world social, economic, and physical barriers that you have to take into account. Do you need to get transportation to enact your plan? Do you need to get childcare because you need to be away from the family? Do you need to be able to get time off from work because you can only enact your plan during business hours? Is there any physical danger to your acting on these plans? I saw that firsthand when I was working in AIDS prevention. I was working with a population of out-of-treatment injection drug users in the projects in North Philadelphia. And one of the men who was participating in my study, the young man, was in high school. And he was absolutely committed to completing high school. And he was talking about what he had to do. And one of the things he talked about was doing his homework, sitting on the floor in his living room. And I thought, oh, well, maybe he just doesn't have any furniture. I mean, he lives in the projects in North Philly. But he said, no, we have furniture. I sit on the floor so I can't be seen through the window and potentially be shot and killed while I'm doing my homework. To reduce these real-world barriers to change to an individual's plans or aspirations or failings is not only insulting, but is ethically reprehensible. We at Centauri had a member who struggled for 5 years to get the benefits that she needed and deserved, and she was only able to do so after we at Centauri intervened. So imagine how hopeless individuals must feel, like this client at Centauri, who tried for 5 years to get the benefits. And the reason why this can lead to hopelessness is due to the fact that when we fail to succeed in our actions, we disproportionately blame that failure on the person rather than these amorphous situational, social, or economic factors that often have more impact on whether we succeed or not. And this is so robust a psychological phenomena, it's actually labeled the fundamental attribution error. And the classic study in psychology will have individuals read what's called a counterintuitive essay, which means that they're reading an essay about something controversial, like, for example, whether you support or oppose Black Lives Matter. And they'll be told that the author was compelled to write this essay and that they did not believe the attitude that they were espousing in the essay. So if they wrote that they were supporting Black Lives Matter, they vehemently opposed it. If they wrote that they were opposing Black Lives Matter, they vehemently supported it. And even though the individuals knew that the person who wrote the essay did not believe what they were writing, they disproportionately attributed that attitude to the writer. They said, if you wrote a counterintuitive essay supporting Black Lives Matter, even if they didn't, they thought, well, they really do support it. And this is a laboratory study with like no stakes at all. When individuals fail to achieve change in the real world, we blame what we see, right? We can see the person. We can't see these individual factors that are forcing our behavior or determining our outcomes. And this kind of hopelessness when you fail because of these issues can really undermine your motivation to take any action. But let's say you overcome all of these factors. We're not done. When you're talking about changing these kind of habitual chronic behaviors that contribute to SDOH, this is not a one and done thing. We need to fight for maintenance, for long-term behavior change. And in order to maintain behavior change, it's crucial that individuals own the change and they internalize it. And if programs are offering these SDOH opportunities, virtually no one is talking about maintenance. And then there's the unofficial sixth step of relapse, which is incredibly common. And a lot of us know this ourselves. How many of us have been on a diet and you've fallen off the wagon, right? You have one slice of cake. You're like, oh, well, I fell off the wagon. I might as well eat the whole cake. Relapse is almost inevitable. So we need to gently and compassionately guide people back to wherever they are in the stage of changing their behavior, so that we destigmatize and normalize the potential for relapse and get them back to changing and maintaining that behavior. And as if this wasn't hard enough, there are two other issues that are unique to changing health behavior. And the first one is a time lag, because when it comes to changing a health behavior, the outcomes are not immediate. So we can't get that kind of instantaneous feedback as to whether this change is making a difference or not. Usually, actually, when you change your health, it's more costly in the beginning. So think about starting an exercise regime, right? When you start to work out, it's actually harder in the beginning with very little positive feedback, because you're working out and not only are your muscles sore and you're out of money on your gym membership, but in the beginning, you have no idea this is making a difference. And when there's a sort of lag between starting a new behavior and seeing an outcome, it also becomes really difficult to determine causality, whether what you did caused the improvement in health. And this is because even if you do see an improvement in health over time, if you're implementing that buffet of SDOH programs that we talked about earlier, you can't definitively know which one caused the other. Because if you're implementing a bunch of stuff at the same time, if you see some improvement in the future, how do you know what caused which? And you can see this in this cartoon, actually. Another huge study found no evidence that cell phones cause cancer. What was the WHO thinking? I think they just got it backwards. Huh? We'll take a look. Here, you can see total cancer is going up, cell phone usage is going up. There are so many problems with that. Just to be safe, until I see more data, I'm going to assume cancer causes cell phones. And as ridiculous as it sounds, it is really difficult to tie things like SDOH programs to specific health outcomes, like a lowered A1C for diabetics. If you have this buffet of resources, you have all these programs were implemented at the same time, and you see this improvement in health, which is related to which. So, to depress the crap out of everybody, you might say, why should payers invest in SDOH, right? If we can't measure a return on investment because we can't directly tie our outcomes, the programs to outcomes, you might even question whether it's the job of payers to invest in costly programs for things that are arguably not directly, at least historically, medically related, like stable housing and transportation. And especially given that most commercial insurance is tied to employment, and members are on average had been changing jobs every 4 years, with millennials changing even more frequently, the payer may not even be around anymore to reap the reward. And this may be why you're seeing more of a focus at the federal level in Medicare Advantage for SDOH programs. But the Medicare Advantage population is older, and you would argue maybe even more difficult to change. So you're definitely going to get more bang for your buck if you could target a younger population, because theoretically, they're going to be more willing to change their behavior, right? And statistically, they have more life years that can be impacted by these behaviors. And then if we're putting on our social justice hat, we could argue that targeting younger folks around these SDOH issues could even target other types of cycles that are so typically found in combination with these, like crime and poverty, as well as disease, for the folks who are living at these intersections of so many SDOH factors. So now we're going to tell you what we at Centauri are proposing to do, as I turn this back to my colleague, Dawn.
Dr. Goldberg. Now, everyone, remember what I said in my earlier slides about how providers will have a role, and I suspect many of you out there, represent hospitals and other providers. Now, those working in patient access are likely to see screening questions built into the EMR or registration system to capture basic information so that financial counselors, social workers, and other staff can provide the appropriate follow-up and referrals to resources. Because it's difficult to ask busy clinicals and other staff to collect additional information above the clinical information, and there is a fine line between alerting providers to important information and not inundating them with too much information, as you heard Dr. Goldberg speak of earlier. The technical infrastructure must also exist to support whichever method is chosen to collect, access, and use the SDOH information, as well as the interoperability to send and receive information to and from non-clinical entities that will provide services in the community to address SDOH. And as I've noted on the slide, you can see where I've noted that screening as soon as possible in the revenue cycle, meaning as close to the provider as possible, rather than waiting until the patient suffers a catastrophic illness, is ideal, so that these factors can be incorporated into the subsequent clinical decision-making. And screening, of course, can occur in multiple ways. There can be paper questionnaires, conversations while discussing treatment options, or through publicly available data sets that give context to where a patient lives and works. And as we've been talking about, payers are all very different in how they address SDOH, so it's important to investigate that as well when you're talking with patients. And I noted here also a link to a very commonly used SDOH screening tool for patient access with strategic questions. And there's a good link for you there if you're interested in taking a look at what something might look like. Next slide, please. Now here, I've noted that EHR and EMR systems present a really golden opportunity to do the following with regard to SDOH. Like we mentioned earlier, collecting SDOH data via screenings, questionnaires, publicly available data sets, or any combination of these. We need to be able to present it in a meaningful way to providers, such as an SDOH summary page or a tab or a view, some way that allows providers to view that as they make these decisions about their patients. And we need a way to integrate it into both clinical and non-clinical care planning, which includes tracking and closing the loop on referrals. And as Dr. Goldberg noted earlier, it doesn't really do much good to give members or anybody all these referrals with no way to know whether or not they were actually acted upon. And so just a few notes here, just so you can see how you might see this presented in the future as you work with clinical and non-clinical systems. Next slide, please. Now here I've actually integrated some links for some different articles and references to screening tools that are very appropriate for like hospital systems and provider systems, just to give you a little bit more information in case this is something that you're interested in investigating further. Because Julie and I certainly could talk all day about social determinants of health and all of the references and resources. So I've just distilled a few here that are very interesting and that will give you a lot more information, most of which is tailored specifically for hospital systems and providers. Next slide, please. And as we bring our presentation to a close today, I just wanted to, provide just a little perspective, on why social determinants of health matters. And it's called It Matters to This One. A man walking along the beach noticed a child tossing things into the ocean. Approaching the boy, he asked, "What are you doing?" The child replied, "Throwing these starfish back into the water. The sun is up and the tide is going out. If I don't throw them back, they'll die." "Son," the man said, "there are miles of beach and hundreds of starfish. Saving a few won't matter." After listening politely, the boy picked up another starfish and smiling said, "It matters to this one." And the point here is addressing SDOH really begins with each of us. And now Dr. Goldberg will close us out for the day.
And this isn't just Dawn and me being liberal and altruistic, although, fess up, we are both liberal and we both strive to be altruistic. But we're going to argue that this is actually all of our problems, and not just that one. Because whether we invest in prevention now to counter the onset of the kind of chronic long-term illnesses that result from SDOH, or we pay later in emergency room visits and prison stays, we all pay in the end. And if we get to choose, we'd prefer that payment invest in giving people the support they need to thrive rather than just struggling to survive while suffering under the conditions inherent to the social determinants of health. With that, questions, random thoughts, you can either enter your questions in the question forum now or contact us later. And this is our contact information for both Dawn and me. Do we have any questions?
Hi, Julie. I don't see any in the chat.
All right, so do we want to let everyone sign off?
Yeah, I think that's good. Everyone can have 20 minutes back in their day. We really appreciate you joining us, and we look forward to working with you soon or seeing you at the CAHAM annual conference in September.
Thank y'all. Have a good one. Take care. Bye.